Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the second in a series of 4 CMEO snacks titled Reinforcing Personalized Care for Uterine Fibroids, Updating Practice to Improve Outcomes. The CMEO snack series is supported by an independent medical education grant from Pfizer. I'm Ayman Al-Hindi, tenured professor and vice chair for research, Department of Obstetrics and Gynecology at the University of Chicago. I'm also a gynecologist, minimally invasive surgeon at University of Chicago Medical Center. Health disparity in uterine fibroids is the primary and has been the primary focus for our research for many years. Our fibroid research program has been NIH funded for the last 22 years continuously. And I'm so proud that our program have received recently on July 15, 2023, the Blossom Award by the White Dress Patient Advocacy Group. I'm joined today by my distinguished colleague, Erica Marsh. Dr. Marsh, could you please introduce yourself?
Absolutely, Dr. Al-Hindi. Hi, I'm Dr. Erica Marsh. I'm a tenured professor and vice chair of the Department of Obstetrics and Gynecology at the University of Michigan in Ann Arbor, Michigan. I am a reproductive endocrinologist and infertility specialist with a clinical focus on fibroids and infertility, and a research focus on health disparities, fibroids, and health equity. I too am a recipient of the Blossom Award from the White Dress Project and am NIH funded, and I'm excited to be here today with you, Dr. Al-Hindi.
Thank you, welcome. To open up the discussion today, let me review our learning objective. Assess the role of GnRH antagonists in long-term treatment based on data and aligned to the estrogen threshold hypothesis. To help the audience have a better understanding of the role of GnRH antagonists, I think it's important to start maybe with a brief introduction to the pathophysiology of the uterine fibroids. As you can see on the slide in front of you now, this is based on some research in our lab, and of course, a lot of contribution from many other groups. This came from an endocrine review article we published in 2022. If you look on the left side of the screen, every female fetus starts with a healthy myometrial tissue. And that also starts from a healthy myometrial stem cell. So now, during pregnancies, during the sensitive time of the development of the uterus, and certainly in the first few months or maybe few years of life, if unfortunately this myometrial stem cell get exposed to a hazardous condition, this could be environmental pollution, especially things that have estrogen-like structure, like phthalate, PSA, etc. Or there could be other contributing factors, such as vitamin D deficiency, some other factors that we'll talk about in a second. This normal myometrial stem cell, which should support the development of a normal myometrium that will never develop fibroid until the end of their productive years around the age of menopause of 52 or so. Unfortunately, this normal myometrial cell then gets converted to an abnormal myometrial stem cell or at-risk myometrial stem cell. And that's the figure in the middle of the screen. This at-risk myometrium still not abnormal enough to develop fibroid, but it already has been primed or reprogrammed to be at risk. Now, if the individual, if the woman then continue to be exposed to these potential risk factors, the same one that we talked about, environmental pollution, vitamin D deficiency, but then additional factors such as increased body weight, obesity, or abnormal bacteria in the uterus or in the gut, what they call microbiome, or chronic stress from things like discrimination, racism, etc. Sometimes all of these factors, or some of them, combine to increase the inflammation in the wall of the uterus, in the myometrium, enough to tip this stem cell into really being a tumor-forming cell. And then a specific mutation emerge, The most common for fibroid is called MYT12 mutation. And once this mutation appears, then unfortunately, this abnormal myometrial stem cell become a fibroid-forming stem cell, and then start to proliferate more and produce a lot of extracellular matrix, the stuff that we see in the fibroid around the cell, things like collagen, fibronectin, proteoglycan, and that's how fibroid starts. And then not only one, but this keep happening all over the myometrium. And as we know, many of the patients have more than one lesion. And this abnormal myometrium continue, unfortunately, for the rest of the woman's life. As we all know, even after we remove these fibroids, let's say during myomectomy, they appear again because the soil, the myometrium, the environment already has been altered, and it will just keep producing fibroid until menopause. Estrogen and progesterone are so important for all of what I told you. They are the driver of abnormal myometrium and the driver of fibroid growth, which form the basis for a lot of the things we're going to talk about today. Another important concept that is very relevant to the pathophysiology of uterine fibroid is the so-called estrogen threshold hypothesis, and the therapeutic window of about 20 to 50 picogram per ml serum level of estradiol. Fibroids love estrogen, and therefore our target for many medical therapeutics has always been to decrease the level of estrogen in the to form the cornerstone in the management of uterine fibroid, while of course trying to minimize the hypoestrogenic adverse side effects. So Dr. Marsh, would you please walk our audience through an understanding of the relevance of estrogen threshold hypothesis to the pathophysiology of uterine fibroid, as well as the pharmacotherapeutics for them?
Absolutely, Dr. Alhindi, I'd be happy to. So as you shared, we know that uterine fibroids really thrive off of exposure to estrogen and progestins, but here we're really focusing on the estrogen piece of the estrogen as a driver of their growth. And as clinicians, you know, we want to do no harm. We know that we know that there are tissues in the body that need estrogen to stay healthy. And then we know that there are also conditions that our patients get that we don't want them to have, including fibroids, conditions like endometriosis, some estrogen responsive cancers even, where we want to minimize the amount of estrogen we have in the body. And so we're trying to find, if you will, that sweet spot where we can identify a window where we can protect the bone and prevent patients from having some of the vasomotor symptoms that they have from when the estrogen gets too low, but also have estrogen levels low enough so that estrogen responsive tissues that are disease tissues like fibroids are not getting enough estrogen to grow and are not getting enough estrogen to thrive.
Excellent. Thank you, Dr. Marsh. So we are really in a way lucky because exactly as you said, Dr. Marsh, the sensitivity or the response of different organs in our body to estrogen are not exactly the same. So we can have enough estrogen to support the health of the bone, for example, as you said, Dr. Marsh, between 20 and 50 picogram per ml of estradiol, which is enough to support the bone and avoid the low estrogen side effects, while not enough to support the fibroid growth. So that's in a way a nice difference between organ sensitivity to estrogen that we definitely want to take advantage of to develop effective therapeutics. So since now we have identified the importance of estrogen threshold hypothesis as it relates to uterine fibroid, I think it's important now to discuss the specific role that GnRH play in addressing the estrogen threshold hypothesis through this unique mechanism of action. So Dr. Marsh, would you please walk our audience through a comparison of the mechanism of action between GnRH agonism versus antagonism, and what this means for the hormonal management of patients with uterine fibroids.
Absolutely. So just to quickly review, GnRH is naturally secreted in the hypothalamus gland and stimulates the pituitary gland to produce FSH and LH. FSH in particular subsequently stimulates the ovary to produce estradiol. Now, there are two types of agents that are available to impact that communication between the hypothalamus and the pituitary by GnRH. One class of those agents is called agonist. The other class is called antagonist. Now, agonists work by honestly initially stimulating GnRH receptors, which causes a transient increase in FSH, LH, and subsequently in estradiol, until there is a downregulation of receptors and a desensitization, if you will, of receptors to GnRH. And then we see a fall in FSH and LH and subsequently a fall in estradiol. While the agonists ultimately lead to a decrease in estrogen, it takes time because it is an indirect effect, if you will. Now, the other class of agents, GnRH antagonists, directly block GnRH receptors in the pituitary. So they are able to immediately or facilitate the immediate decrease in LH and FSH, and a much more rapid decrease, therefore, in estradiol levels. So while both of these classes of agents ultimately lead to falls in estrogen levels, the antagonist class works more directly and leads to a much more rapid and immediate decrease in FSH and LH and subsequently in estrogen.
Thank you. Very well said, Dr. Marsh. So another, I would say, major separation or advantage for this newer group of GnRH antagonists is all the GnRH agonists we used to have for the last 20, 25 years. They were peptides, so we really couldn't take them orally because they would be, exactly, they will be destroyed in the GI tract. So we used to have them by injection or nasal spray, etc. But this new family of compounds, the GnRH antagonists, they are not peptide. So we can easily take them orally, and actually, you know, the two FDA approved medication now available in that family are oral medication, which is so convenient for the patient and easy to utilize, and that improves compliance of the patient. So excellent. So now that we have explored the unique role of GnRH antagonists, I think it's important we examine the treatment options that we have for the treatment of uterine fibroids. Starting with the medical treatment, it's especially important that providers adapt to being able to communicate the risk, benefits, and side effects to patients, so patients can make informed personal choices when selecting treatment. So Dr. Marsh, can you please walk us through the medication therapy available and how you would discuss these options with patients in your clinical practice?
Absolutely, Dr. Ohendi. I tend to start as a first-line agent with combined oral contraceptives. That's a class of medication that many individuals have experience with, have taken at some point in their life, and are familiar or are familiar with. And from a price perspective, they tend to be at one of the lower price points of agents that we can start with. Basically, combined oral contraceptives work by inhibiting ovulation, which ultimately lowers overall estrogen and progestin secretion. They are, however, associated with a slightly increased risk of thromboembolic events or clotting events, and as well as a very, very, very low chance of a condition called hepatocellular adenoma. I then typically, if combined oral contraceptives are not effective in my patients, I tend to transition to progestin-only agents, and typically oral progestin agents as a start. They work also by inhibiting ovulation, thereby inhibiting overall sex steroid synthesis. And they also thin the endometrium, lowering the net amount of bleeding a patient will have. These agents, similar to combined oral contraceptive agents, are effective with bleeding. And in fact, with progestin-only medications, a small portion, a small but significant portion of patients will actually stop having periods altogether. The risk of progestin-only agents is with prolonged use, specifically of the injectable agents. There's evidence of loss of bone mass, so you have to be careful with that. If progestins, particularly oral progestins, are not effective, I tend to offer patients intrauterine system that contains a levonorgestrel releasing mechanism, which results in thinning out the endometrium and lowering or decreasing the amount of bleeding through that primary mechanism. Depending, though, on the size of the uterine cavity and the contour of the cavity and number of fibroids that are potentially in the cavity, that may not be a valuable option due to increased risk of the device being expulsed or poorly retained. If all of these agents fail, I then will offer the patient a GnRH antagonist. We've just reviewed the mechanism for GnRH antagonist, and as you highlighted, Dr. Al-Hindi, these medications are good options because they can be taken orally. In contrast to the GnRH agonist. Now, as we said previously, these agents immediately block the impact of GnRH on the pituitary, and which leads to the immediate decrease in FSH and LH and an immediate state of hypoestrogenism. That low estrogen level leads to not only a decrease in uterine bleeding, and in many patients, no further uterine bleeding, but in some patients also leads to a decrease in uterine volume. The challenge with GnRH antagonist or agonist, I tend to use antagonist primarily just because patients prefer an oral mechanism, is the loss of bone mass with prolonged use. But as we'll discuss later, there are some agents that actually include a small amount of estrogen and progestin so that bone loss is in fact minimized. Sperms are another class of medications that have been shown to decrease inhibiting, ovulation. I do not regularly use sperms in my patient population, but there have been some published small trials in US populations, and actually very large trials in European populations where sperms have been shown to be highly effective. Unfortunately, the primary protocol and medication that has been shown to be effective in fibroids in the large European studies is not approved by the FDA in the US.
Excellent. Thank you, Dr. Marsh, for this comprehensive coverage of all the, really, you covered all the medical treatment options for uterine fibroids. Just a couple of points. You mentioned sperm. So for our audience, sperm stands for selective progesterone receptor modulator, things like ulipristal, for example. But as you quite correctly said, I want to emphasize this is not approved in the United States, never achieved approval by the FDA for uterine fibroids. And indeed, it was approved in Europe and Canada and other countries for a while. But as you quite correctly said, Dr. Marsh, because of potential liver issues, this approval, even in other countries, has been very limited to only very specific cases and so on. So, no, this is fantastic coverage. I just want to say, and it's really great to kind of demonstrate maybe different patterns of clinical practice. I personally, and maybe it's a reflection of many of the patients I see with uterine fibroids, have already tried things like birth control pills, etc., and potentially failed. That's why they
Yes.
get to see me. I actually like to quite early use oral GnRH antagonists. The two options available in the US, approved by the FDA, as we know, because they have really gone through a very rigorous, large phase 3 clinical trial program against uterine fibroids. Many of the other options that we have been using and improvising in a way for years to help our fibroid patients, we have been really improvising. As I said, we have built a lot of this on accumulation of clinical practice, kind of common sense mechanism of action, etc., to thin the endometrium, as you said. But many of them have not really gone through a rigorous clinical research programs in patients with fibroid. Mm-hmm. So now with the two available FDA-approved oral GnRH antagonists, I personally in my practice tend to use them quite early to help my patients with uterine fibroids. Mm-hmm. Now we have covered the medical treatment options very well. Thank you, Dr. Marsh. Could you please now do the same and discuss the surgical and interventional treatment options that are currently available, relating how you communicate them with your patient, and while also discussing a relevant selection strategy for providers?
Absolutely, Dr. Al-Hindi. So in terms of surgical and interventional options, I'll start with the surgical options for fibroids, and they are 1, myomectomy, and 2, hysterectomy. Now, myomectomy, as we know, involves the removal of the fibroids themselves, but leaving the uterus intact, whereas hysterectomy involves removing the entire uterus. Hysterectomy is the only definitive therapy that is available for fibroids. The only therapy that we have, or only intervention, I should say, that we have where we can tell a patient, we're sure you are never going to get another fibroid. Unfortunately, hysterectomy is not a viable option for many of our patients, who, particularly patients who want to maintain the ability to bear children, or simply just want to keep their uterus because they want to keep their uterus independent of any plans for future childbearing. So for patients that want definitive treatment and are done with childbearing, hysterectomy is a very reasonable surgical option. For patients that want to retain their uterus, myomectomy is a much more appropriate surgical option. Now, with both of these surgical procedures, there are many different approaches that can be taken. They're going to be driven by the size of the fibroids, the number of the fibroids, the nature of the fibroids. On imaging, is there any concern about the appearance of the fibroids, that they may not be fibroids? And it also is going to depend on the risk profile of the patient and the skill of the the healthcare provider. The different types of approaches include open procedures that typically involve larger surgical incisions, longer hospital stays, and longer recovery times. Those types of approaches are typically used in patients with many and or large fibroids. There's also minimally invasive procedures that physicians like Dr. El-Hindi perform that can be done laparoscopically or with the robot. There are also, those procedures involve anywhere from perhaps 3 to occasionally 4 or 5 very small incisions in the abdomen. Sometimes the patients can go home the same day. Sometimes they may spend one night in the hospital, and the recovery time is typically much shorter than it is with open procedures. There's also an approach called hysteroscopic myomectomy, where there are actually no incisions at all, and where the fibroids are approached via the cervix. So the entire procedure is done via instruments that are inserted via the vagina through the cervix into the uterine cavity, and fibroids are essentially shaved down and removed that way. You know, there are limitations for many of these procedures, depending on size, again, on patient health and medical history, patient goals, physician comfort. But the primary driver for really selection of these for any of these procedures should be the patient choice and safety, of course. There are 2 procedures performed in addition to the surgical procedures by our interventional radiology colleagues. One is called uterine artery embolization, and the other is called MRI guided focused ultrasound procedure. Between these 2, uterine artery embolization, or uterine fibroid embolization, as it's also known, is the far older of the procedures. There's much more data on that procedure, and this is a procedure where the vessels that feed the uterus and the fibroid are accessed by the radiologist via the groin area, and catheters are used to block the blood supply to certain parts of the uterus and to fibroids directly. So the result is that there's a decreased blood supply to the fibroids, and that involves ultimately shrinkage of the fibroids and a decrease in bleeding. I think this procedure is generally well received. It is not ideal for all kinds of fibroids, and is associated with a recurrence rate of about 20% or so, at less than 3 years. We also currently, this procedure is not approved by the FDA for patients who want the ability to have children in the future. So for patients that are done with childbearing, that the uterine artery embolization or uterine fibroid embolization is, and those patients who are having bleeding and or bulk symptoms, that's a reasonable procedure to offer patients, particularly patients who are not good candidates for, or who simply decline surgical intervention. The other interventional radiological treatment option, which is the MRI guided focused ultrasound procedure, is a procedure where we use high density ultrasound waves to essentially destroy fibroid tissue. I think that this procedure is again one of the newer procedures. It is non-invasive, so that has appealed to some patients. and it also has a short recovery time. The concern with this is that the symptom improvement profile is not as good as it is with surgical options or UAE. And it is only the patients for whom this is this procedure can work are highly specific. The fibroids have to be in a certain place, of a certain size, and so that they're and of a certain number, quite frankly. And so there are many patients for whom this procedure is not perhaps the ideal treatment option, because the effectiveness of the treatment is not as generalizable as some of the other treatment options. This is also a treatment where its impact on future fertility is this is not a procedure that would be recommended for patients who had plans for future childbearing. There's a lot more I could say about all of these procedures, Dr. Al-Hindi. We could spend, hours talking about any one of them, but I think that in a nutshell, speaks to what they are, perhaps the ideal patients for each of the categories, and when you wouldn't want to offer those treatments to patients. Do you have anything to add?
Actually, I love this last comment because this would be a great segue, because I was just about to remind our audience that if they are interested in more information on important consideration when assessing, diagnosing, or clinically managing uterine fibroid, they can access our program titled Guiding the Clinical Management of Uterine Fibroids on this same educational hub, which they will find a lot more information on all the things we talked about. Fantastic. Thank you, Dr. Marsh. So after discussing the surgical and interventional strategy now, I want to take maybe a closer look at the safety, efficacy, and long-term treatment outcome of GnRH antagonists in practice, because these really are the newer, exciting family of compounds that received FDA approval recently in the last few years. So I like to maybe zoom a little bit on that. With this newer treatment options, I think it's important providers are aware of the most up-to-date literature so they can ensure patients are able to make informed decisions before selecting a specific treatment. So Dr. Marsh, would you please outline for the audience the importance of the Liberty program and the Ilaris program for practitioners?
Absolutely. So as you mentioned, Dr. Al-Hindi, there are two agents that are currently FDA approved that fall into that class of GnRH antagonists that we talked about earlier. So again, oral agents that directly antagonize GnRH at the level of the pituitary. Both of these products, which are relugolix and elagolix, have been well studied and have completed large randomized controlled trials that have been both published in high impact journals that are available for anybody in the audience to review. Relugolix is a single use per day agent, so 1 time a day agent that includes combination therapy of a small amount of estrogen and progestin. The estrogen is to make sure that we are optimized protecting bone and minimizing vasomotor symptoms, but is at a low enough level that we are not feeding the fibroids, if you will. The progestin is included because we cannot give unopposed estrogen in patients that have a uterus, as you well know. So we have to give estrogen, we have to give progestins when we're giving patients estrogen to protect the endometrium. So that is why we give the estrogen, again, to protect the bone and to minimize vasomotor symptoms, and we give the progestin to protect the endometrium. And that is the relugolix, which is a 1 time a day therapy, and that is FDA approved for up to 2 years of use. The other agent that we have is elagolix, which is, again, also a GnRH antagonist that can be given with add-back therapy, specifically an estrogen and a progesterone, for the reasons that we've already mentioned, to minimize vasomotor symptoms, to protect the bone, while not giving too much estrogen as to feed the fibroid or promote fibroid growth. Similar to relugolix, elagolix is FDA approved for up to 2 years use, but different from relugolix. Elagolix requires being given twice a day instead of once a day. Now, both of these agents are associated with improved heavy menstrual bleeding, as well as a maintenance of bone mineral density, which is something that all of us as providers struggle with. I think the primary difference in the 2 agents, again, is that relugolix is once a day, elagolix is twice a day.
Fantastic. So once again, well said. I think the way you have presented the information makes it very clear for the audience how the newer agents offer symptom relief. I would say unlike other treatments in this space. What I also like, particularly Dr. Marsh, about those 2 new FDA-approved oral GnRH antagonists, as I mentioned earlier, they came to us after rigorous, high-quality, large phase 3 clinical trial program.
Yes.
Some of them include close to 1,000 patients. So we have data that we are reliable, and as you mentioned, published in high-impact journal. Many of my patients also like to know exactly what to expect. So if I use this medication, what should I expect next cycle or 2 cycles down the road? And because of this information available from these studies, I tell her, after 1 month, you should expect around 50% reduction in your menstrual blood loss. And then if you stay on it, then that actually goes to about 90% reduction. And 70% of patients who actually used either of those 2 medications actually stop bleeding altogether. Have amenorrhea. So I have good data I can share with my patient, and many of my patients appreciate that, to know what to expect.
Absolutely, Dr. El-Hindi. And I think the another really reassuring aspect of both of these medications is the safety profile, which was presented very nicely in both of the large trials, or both of the trials, or all of the trials really, for both of these medications, which reassures us as providers that we are doing no harm, which is a first. It's a first priority for us, particularly when considering a newer class of medication. These are medications that are not associated with increased risks of blood clots or increased loss of bone health, as we see in some of the other GnRH analogs.
Excellent. So we have really covered a lot of grounds here. So lastly, we have again been trying to emphasize the importance of informed decision-making for patients when managing uterine fibroids in practice. So Dr. Marsh, would you please walk us through some questions that you have encountered in your practice regarding the specific treatments and how you address those questions in practice?
Absolutely. I know we opened up talking about the estrogen threshold hypothesis, Dr. El-Hindi, and it's funny. I've never had a colleague walk up to me and ask me, how does this medication fit within the estrogen threshold hypothesis? But very relevant to that hypothesis, I've had many colleagues come up and say, and ask me, what are the implications for my patient's bone health? Do I need to scan, send my patients for a DEXA when starting this medication, or while the patient is on the medication and during that 2-year window? And so, it's nice to be able to say that based on the published randomized controlled trial data, that bone health is protected in these agents. Just starting the medication isn't an indication itself for extra bone monitoring. I've also had colleagues ask me and patients ask me, what do I need to keep, or should I keep my patient on their oral contraceptive medication while starting this? And that's a very emphatic no. This is not a medication that you would use in addition to other sex steroid hormone medications. This should be the only medication that the patient is taking that contains any type of sex steroid. And again, should by itself suffice in terms of treating primarily the heavy menstrual bleeding, but in many patients also having some impact on size and pain. Another, I guess, question that I get is, how long can I stay on this medication? And it's important to reassure both our colleagues and our patients is that these medications are FDA approved for 2 years. Some of the previous GnRH analogs that that are FDA approved are approved really only for 6 months of use. Which is very limiting for many of our patients and for us as providers. But both of these agents are approved for 2 years of use by the FDA, which is very helpful. So I think overall, we have an agent that is oral, that is safe, that we can give our patients for an extended period of time, and can be used in and of themselves as long-term long-term agents, and also can be used as shorter-term bridge agents for patients who just need a moment of pause from their symptoms and relief of the symptoms to think and consider what they want to do long term. I think this is a safe, low risk intervention that can allow them that window. So back to you, Dr. Ahundi. Any other questions?
Absolutely. No, I think those are great insights from practice, Dr. Marsh. I would also like to encourage the audience, if they are interested in more techniques to improve communication while treatment planning with patient, to access this program, Enhancing the Value of Choice for the Clinical Management of Uterine Fibroid through Shared Decision Making. That's also available on the same educational hub. So I would like to actually summarize today's discussion by walking through our SMART goals, which are specific, measurable, attainable, relevant, and timely. That's the SMART acronym. This is what I hope that you will take away from this presentation to apply in your practice. 1, explore the pathophysiology of uterine fibroids. 2, you understand the relevance of the estrogen threshold hypothesis on the pathophysiology of uterine fibroid. 3, identify the mechanism of GnRH antagonist in the treatment of uterine fibroid. And 4, appraise the latest data regarding GnRH antagonist aligned to the estrogen threshold hypothesis. I would also like to encourage everyone to visit the CMEO Virtual Education Hub, which provides free resources and education for healthcare providers and patients on uterine fibroid. This CMEO snack is one of a 4-part series that is continuous initiative to reinforce personalized care for uterine fibroids, update practices, and improve patient outcome. We hope that you will take advantage and participate in all of the activities in this series. The other topics will be covered include understanding the impact of uterine fibroids, guiding the clinical management of uterine fibroids, and incorporating shared decision-making into practice to enhance the value of choice for our patient with uterine fibroids. Dr. Marsh, it's a pleasure, and thank you again so much for teaching us today and for such great conversation. I hope our audience have learned a lot about the hypothalamic pituitary ovarian axis and the estrogen threshold hypothesis in uterine fibroids and how it has paved the way for novel treatment. To receive credit for this activity, please complete the post-test and evaluation. We appreciate your feedback and want to hear from you. Tell us what you liked about this program and how can we continue to improve, and what additional topics you would like us to address. I want to sincerely thank you for your commitment to continuing your education on uterine fibroids. Together, we can strive to provide the best care for our patients who have this very common condition. Thank you very much.